Good morning, respected teacher, my colleague, seniors. I'll be presenting in about margin adequacy in soft tissue tumors. I am Dr. Sandeep Sapkota, and I am a super specialty resident at BPKMCH in surgical oncology stream. So much has been already discussed about soft tissue sarcoma, but I'll say in very brief that it is a rare heterogeneous group of malignant tumors arising from the mesenchymal tissue, accounting for approximately around 1% in adult and around 7 to 10% in pediatric cancer. It is rare, but not so rare if we look at the total soft tissue sarcoma in appendices. So most common site is extremities. That's what I meant. That is around 60% is present in extremities, and which is all followed by trunk, retroperitoneum, and head and neck as well. So why are soft tissue sarcoma a challenging case for us is because there are varieties of histological subtypes with variable biology, with variable treatment as well. So high-grade tumors, they are usually prone to local recurrence and distant mets, lung being of course most common, and the treatment requires multidisciplinary care with the surgery plus minus radiotherapy and then chemotherapy. And the next question for today's presentation comes why margin matters in soft tissue sarcoma. So surgical resection is the curative treatment in this. The margin adequacy, it directly impacts the local control, functional preservation, and sometimes the overall survival as well. So it sets the stage for us to ask that why understanding margin width and status is crucial, and it guides for the re-excision and influences the use of adjuvant therapy. And literature also suggests that the margin is the main factor for distant mets as well. Many literature has also recorded the distant mets free survival in the case of R0 or R1 resection. So it may be there can be myriads of classification as we have discussed in last class also, but very briefly it can be classified according to its behavior biologically, that it may be benign, intermediate or malignant. Intermediate like desmoid tumors or DFSP, and then malignant like some liposarcoma, and then other sarcomas fibrosarcoma, hemangiosarcoma, and so on. So the treatment our treatment varies according to the behavior of the tumor. So it can be classified as this as well, and there is histologic classification. It was presented detailed in our last class. There is a WSO classification according to the tumor of origin or site of origin of the tumor. So it can be adipocytic, fibroblastic, or fibrohistiocytic, or smooth muscle tumor, or skeletal muscle tumor, vascular tumors, or peripheral nerve sheath tumors, and tumors of uncertain differentiation. And the names can be seen in the screen. So I'll skip these to brief my presentation. And there's also FNC LCC grading system based on the 3 parameters, that is tumor differentiation, mitotic count, and tumor necrosis. These are for pathologists, which differentiate or grades these to grade 1, grade 2, and grade 3. And obviously these grades again determines the tumor biology. The higher grade tumors have highest risk of recurrence, so which drives our margin decision and radiotherapy decision as well. So there may be clinical classification by site or by depth, that is superficial versus deep. Deep of course are usually higher grade and they have high local recurrence, so we may have to go for more radical excision or wider excision during the treatment. And there can also be molecular classification with the key translocation seen in the ISC, that is those with the translocation in X18, that is synovial sarcoma, or 12-16 chromosome can be myxoid liposarcoma. The very common, the MD-M2 amplification, it is seen in well differentiated or dedifferentiated liposarcoma, and then also SMAR CB1 loss in epithelioid sarcoma, and so on. The most common one used being the histological classification by WSO, and then the clinical classification by clinician, that is benign, intermediate, malignant. So with this purpose, I did the literature review from 2010 to 2025, 15 years of span, and I reviewed around 10 key articles published in this span, and included the selected classical and ancient reference literature as well, which I'll talk in the next slide. and the thorough research has been performed through PubMed and Google Scholar. I avoided other articles, and the key words that I used for the literature review are given in the slides, with the main objective of discussing the surgical margin and different margin classification system and evidences that can be obtained from the literature regarding the margin, and the use of modern imaging like MRI and radiomics to discuss on some. So much of my talk has been derived from the article by Samri et al. From 2021, and then other articles like this from 2025, and then another by Miles et al. So all these boils to the single point that was given by the very preliminary study by Kawaguchi, the concept of the curative margin in surgery for bone and soft tissue sarcoma. So this was published in 1995, where 1,329 patients with bone and soft tissue sarcoma were studied, of which 492 were excluded. So there were overall 837 patients. And the gist was, when preoperative treatment is not done or is ineffective in high-grade sarcoma, the margin greater than 3 cm wide is necessary. When the preoperative modality is effective, a 2 cm margin is permissible. However, for recurrent sarcoma, low-grade or high-grade, a curative procedure is necessary. So this was the main article on the basis of which further developments were done in the field of margin adequacy. There are multiple classification used. To name some: the Inecking classification, R classification, that is also endorsed by AJCC, and then UICC endorsed R plus 1 mm classification, and the dichotomous classification, which was the ancient one, and the direct measurement of the margin distance is also another used system. So I'll discuss about each system briefly. As there are multiple margin classification systems, the inconsistency of definition of positive and negative margin across centers are seen in case of the soft tissue sarcoma. So, if we look at the result of the meta-analysis, we can see that I have highlighted that R0 resection has significantly lesser local recurrence versus the R1 recurrence, and the one thing is sure that the positive margin directly influence the survival and local recurrence of the patient. This was also endorsed by other meta-analysis, which has the same result as well. So this Kaplan-Meier curve, we can see it compares the local recurrence in multiple system, that is R0, 0 to, with margin 0 to 1 mm, 1 to 2 mm, and then more than 2 mm. So the main thing here is, if there is the margin is more than 5 mm, the overall survival is very good, we can see. If the margin is R plus, that is positive margin restriction, there is a certain dip in Kaplan-Meier curve which depicts the events. So it has the lesser overall survival. Again, the distant METs-free survival, it is directly proportional to the margin status. The R1 has the poorest METs-free survival. We can see multiple number of the patient being succumbed to the metastasis early, and the more than 5 mm resection have a good prognosis if we look at the metastatic potential as well. So that's why the margin, this is for the resection margin and cumulative overall survival. Again, the scenario is same. R plus margin has worst survival compared to the more than 5 mm margin. So the study about margin is inevitable in case of the soft tissue sarcoma. The earlier dichotomous classification, that is positive versus negative margin, is now abandoned. It is not recommended because positive margin, as it is are microscopic or macroscopic positive, are not shown along the system. So another Inecking classification in 1980 for musculoskeletal sarcoma was proposed. So this is our working classification. As we can see, the 4 margin type, that is intralesional, marginal, wide, and radical. This is the Inecking classification of the margin system. Intralesional is when we perform the biopsy, seen in incisional biopsy, or some debulking procedure that we pass through the tumor. The capsule is violated, the field is already contaminated, we can say. And the marginal is resection is done through pseudocapsule or reactive zone, mainly that is seen in the excisional biopsy that we commonly do, or enucleation. So wider is should be our, so for the benign tumors, the marginal excision should be our biopsy. Basic concept is that, and for malignant tumors, according to the involvement, wide or radical treatment should be our goal for the management. So wider is tumor is removed with a cuff of normal tissue, but the dissection remains within the same compartment, and radical is removal of the entire anatomic compartment. We'll discuss this more on when I talk about the satellite and skip lesion. So radical or compartmental dissection is done in case of the skip lesions. The entire compartment is removed. So another classification system is R classification, which is also endorsed by AJCC. Third edition AJCC writes about the R classification in its manual, that R0 is microscopically negative margin, that is no tumor cell is inked at margin. R1 is microscopically positive. R2 is grossly positive, that is there is a visible tumor grossly left behind in the surgical bed. So another classification system is UICC classification, or R plus 1 mm classification. The advantage of R plus 1 classification can be seen from the literature by Cribb et al. I'll show it in the next slide. It is a modification of R, and the margin definition is R2 is grossly positive, it is same. R1 is microscopically positive, that is tumor is within the 1 mm of the inked margin, that is it keeps the margin as 1 mm. And R0 is there is more than 1 mm of margin is ink free. So this is the summary of the various classification that you can see. MSTS or Enneking classification, AJCC, UICC that I talked about. Tumor clearance, that is it measures the metric distance from edge of the tumor to the surgical margin. And then TMCC, which is negative margin, unplanned positive or planned positive, or sometimes hoop surgery as well. It is endorsed by the Toronto margin context classification, but not used commonly worldwide. And then the margin quality, the quality of the tissue that is extracted during the surgery also matter. If the barrier is breached or not, or if the tumor is the sheath, fascial sheath is removed along with the tumor. So that is the anatomical factor, a composition of the tissue that matters is also another classification. So this is the cumulative probability of the local recurrence in case of the R0, R1 and R2 resection, the R2 resection being the more prone for recurrence. And this one here, it shows the potential. If the margin is less than 1 mm, there is a potential of recurrence, higher chance of recurrence with high hazard ratio in the later stages. So UICC R plus 1 system with the margin more than 1 mm margin have 8 to 10 years local survival. So 1 mm margin, less than 1 mm margin may be inefficient if we go through the UICC staging. So another is the article from Levitan et al. So the traditional R classification, R0 resection has 8% recurrence. This is the 10-year outcome. R1 has 21% recurrence and R2 has 44% recurrence. Of course, more tumor is called to higher recurrence. The R plus 1 system correlates equivalently with the recurrence and METS rate. And then the TMCC staging is very vague. But all the data they present to other positive margin has a higher recurrence, and accidental tumor breach, it also dramatically raises the recurrence rate. So why 1 mm is acceptable and when it is not? So we can say the soft tissue sarcoma, it spreads along the fascial planes. It is not wildly infiltrative as the other carcinomas or epithelial derived tumors, and even small clear margins are effective if the dissection is carried along the barrier. As I talked, the fascia, periosteum or epineurium, these are the anatomical barrier. If it is carefully carried, the dissection is carefully carried around it, so 1 mm margin is acceptable. If there is no tumor spill or if the neoadjuvant treatment is proper as per the cases, 1 mm margin is acceptable. But the margin is not adequate if the tumor was cell out or marginally excised, tumor is high grade or deep, there was contamination during the surgery, or margin isn't fat only rather than on an anatomical barrier. So then the margin, 1 mm margin would not be deemed adequate. What we'll do next if the margin is inadequate, I'll talk it in the next slide. So Before that, the role of modern imaging in margin assessment of soft tissue sarcoma. Many book writes about the triple assessment in soft tissue sarcoma, that is assessment of the local site using MRI, and then the core cut biopsy, and then the CT for distant metastasis. This is the triple assessment in STS. And modern imaging, especially MRI, has enabled us to perform the limb sparing surgery with the adequate or comparable oncological outcome. So this is given, the MRI being the most sensitive and accurate tool for margin assessment. It is best for defining tumor extent and infiltration. So this we should always keep in mind, that there are several MRI features that correlate with the margin invasion and asserted local recurrence. There can be homogeneity or heterogeneity of the tissue, the angiogenesis, peritumoral invasion, peritumoral enhancement, peritumoral swelling. These all correlate to the aggressiveness or invasiveness of the tissue. So the infiltrative growth pattern is the most important MRI predictor for our margin adequacy. Irregular tumor surface, they spreads into surrounding tissue and may need wider margin. There can be focal tumor or diffuse tumor, more than 25% diffuse, which is strongly associated with the satellite tumor and histology. And another is the tail sign, which is seen in Myxopharma and UPS. I'll show it in next slide. It is also a marker of the infiltrative behavior, and it is associated with the local recurrence, which requires the broader classification. So if we see the DICOM image in the MRI, there is a tail sign, that is the tumor curvilinear extension of the tumor, which is going out of the fascial sheath. In T2 image also you can see it's better seen in this one. So it looks like a thin tail of tumor extending beyond the visible bulk, which is strongly associated with the satellite tumor also. So wider margin are required. And to look for some future advancement, I also did a literature search on radiomics, or the use of radiomics. That is the most important software, that is Mimics by Material Mimics from USA. They are using the radiomics in soft tissue sarcoma towards the precision imaging in oncology. That is, it gives the quantitative imaging analysis using AI. It extracts the texture, shape, and pixel pattern from the MRI and predicts the margin invasion in several cancers, which have a potential to quantify the required margin or possible margin infiltration. But the more data are required. But the most distinguishing use of radiomics is being done to determine the benign versus malignant, and the studies have shown that the radiomics or AI has been already proven better than some radiologists to distinguish the soft tissue sarcoma from benign and malignant. We can see the accuracy, specificity, and positive prediction value is significantly higher in case of the radiomics. If we go through this article, the area under the curve is also significant. However, the p-value is not statistically significant. So there are some specific considerations that we need to follow in soft tissue sarcomas. First one is invasive soft tissue sarcoma, that is one with the tail sign, which has a local recurrence of up to 20 to 30%. So even with negative margin, there is a high chance of local recurrence in these cases, as seen by different authors. So we need to follow and then do some adjuvant treatment in these cases as per the case scenario. Then on the consideration being the periosteal margin, that is soft tissue sarcoma near bone, or assess for the bone invasion with MRI and CT. So bone invasion definitely shows the poorer prognosis. Study of 50 periosteal soft tissue sarcoma, only 6% had true bone invasion, which lead to the local recurrence in 16%. So to conclude, the periosteum is a strong barrier. So bone penetration is rare, but bone resection is recommended only when frank invasion is seen on imaging. And standard treatment is still the wide excision plus subperiosteal dissection plus radiation to bone. However, should be cautious that there is always the radiation associated fracture in these may be seen in these cases. And then prophylactic IM nailing can be done to prevent this as well if the patient is old, high radiation dose is to be given, or low bone mineral density is seen. Then another is the STS of the hand, which avoid us from doing aggressive wide resection. Also, the radiotherapy is very difficult in these cases because of the chance of contracture. So in these limited structure, the positive margin rate after surgery may range up to 11 to 40%, and which ultimately leads to the lesser 5-year overall survival. So if margin negative seems impossible, amputation should always be considered in these cases. As I said, the RT is, even though it is not contraindicated, but is associated with the contracture or deformity, osteitis as well. MD Anderson approach, they recommend 50 gyrem preoperative RT for cases with the expected closed margin in case of the hand and foot soft tissue sarcoma. The foot has the similar scenario, but the functional loss of digits is less impactful than hand, so the resection can be more aggressive, as well as we can undergo the amputation with some good prosthesis as well. Then another is the topic of lymph node metastasis and sentinel node biopsy. We know the sarcomas, they do not metastasize via lymph node, but there are some exceptions, being rhabdomyoid sarcoma, clear cell sarcoma, epithelioid sarcoma, and synovial sarcoma. The sentinel lymph node biopsy has a limited value in synovial sarcoma and may be useful in clear cell sarcoma, detecting the occult lymph node metastasis. But it is uncertain and the data are very limited, and the role of SLNB should be very personalized in case of STSs. Another is the hoop surgery, that is the unplanned excision or excision without good diagnostic workup. So in these cases, re-resection should always remove the entire surgical bed. That is, we should always opt for the radical resection in second resection surgery. And another is the concept of satellite and skip lesion that we should keep in mind. For local assessment of the soft tissue sarcoma, the MRI should be done of the whole limb to look for the whole compartment, not of the specific site, and that is one key. So to differentiate with the satellite lesion or skip lesion, the location, in case of satellite lesion, it is within the reactive zone or pseudocapsule. Some article also write satellite within 5 cm and skip lesion out of 5 cm, but generally it is the satellite is within the reactive zone in same compartment. Skip lesions are outside of the reactive zone in non-contiguous area in distant compartment. And satellite lesions are not the true mets, they are the microscopic extension, whereas skip lesions are considered the regional mets and has the worst prognosis and should be the management alters accordingly. So the satellite lesion demands the wide excision, which must include the reactive zone, or marginal excision risks the local recurrence, whereas the skip lesion requires the radical or compartmental resection to remove all tumor foci. So to briefly, the management overview would be, if it is benign, the very small lesion can be observed if asymptomatic, or marginal excision, that is outside of the pseudocapsule if symptomatic or enlarging. For malignant, the triple assessment, as I said, and then we should always plan for curative versus palliative management. The limb sparing is the way to go, and the radical excision should be incorporated with the limb sparing excision. Radiotherapy for the selected case and adjuvant and proper neoadjuvant according to the subtypes should be used. So this is the algorithm that I have included. The patient presents with soft tissue mass, we should take the full history plus examination. This was discussed in last class, and then MRI with the contrast, which define the extent and planes, and then biopsy, and then staging with the CT scan. So biopsy confirms that it is benign, then it should be managed as benign tumor. If it confirms that it is a malignant, then CT staging and multidisciplinary board discussion is the core of the cancer treatment in modern scenario or era. Then we should decide the treatment. So treatment can be neoadjuvant. The detail of each and every histological subtypes has not been discussed in today's presentation. But then, of course, the neoadjuvant, as for the infiltration of the tumor, or straight to the surgery, where we should aim for the R0 margin. So neoadjuvant, either chemo or RT or both, we should assess the response after the limb cycle, recommended cycle. Using the MRI, if there is a good response, then we should always proceed with the surgery, which is only the curative or definitive management. If we aim to the surgery directly, we should aim for the R0 resection and perform the oncologic resection with the limb salvage procedures as much as possible. So after the pathological sample, if we get R0, follow-up only is considerable. If it is R1, then in case of soft tissue sarcomas, then re-resection is always feasible. If not feasible, then radiation therapy to surgery bed can be done, but there is a landmark randomized trial where the local recurrence with RT is shown to be 1.4% and local recurrence without RT is 23.9% in these cases, that is in R1 cases. In case of R2, re-resection or amputation is the way to go. RT won't control the local recurrence in these cases. So the adequate surgical margin, even though it has been a topic of discussion for quite some time, it still remains a critical determinant for the survival of the patient. Where the margin is positive, re-resection is always preferred, and adjuvant therapy significantly reduce the recurrence risk, but R2 resection should always be taken for resurgery. And advances in imaging and the reconstruct techniques and multidisciplinary care has now allowed for more than 90% limb sparing rates with the acceptable oncological outcome. So the limb salvage with the oncological principal preservation should always be considered.